when we use the total return glycolysis, it is defined as the product of the mean SUV and the MTV of tumor tissue above a minimum SUV threshold. So if we, I will show you the example. This is a PET image of a patient with osteosarcoma in the right femur. You can see hypermetabolic mass in the right femur, and if we just click the image, then we can acquire the many parameters here. Actually, the volume of interest was defined as the tumor regions with the SUV higher than 2.0 of SUV. As you can see in the left image, you can measure the SUV max and the SUV mean, average SUV, and the volume of the metabolic tumor volume. This means the tumor volume with the SUV more than 2.0. So SUV max in this case is 6.3, and if the threshold is 2.0, it is about more than 200 milliliter. And if we produce these two parameters, we can calculate the TLG, total lesion glycolysis. Using these parameters, we can predict the survival in osteosarcoma. If we measure the metabolic tumor volume, the specific threshold 2.0, we could predict the survival of the patients with tumor with larger metabolic tumor volume showed poor prognosis than the others. Yes, SUV and MTV or TLG are very popular in clinical studies, but researchers have studied many other parameters in PET. One of them is retention index. Retention index is defined as the increase in SUV over region in the delayed phase imaging divided by the SUV in the early phase imaging. As you can see in this image, we acquire the early PET, which means the FDG injection. Then after 60 minutes, we acquire the early PET. It is usually the standard protocol. But after more than 2 hours, we acquire the second about 12. So the retention index calculated as the with the following formula, and it was about 33%. It means that on delayed PET image, SUV max increased more than 30% compared to the early PET image. Then why does SUV increase? Why did SUV increase on delayed PET? Delayed images.
Why increase?
Yeah.
That because maybe kinase is increased.
Sure.
Because 6-phosphate is an increase in tumor cells.
Sure. Very good. Yes, I will explain it. Yeah. It is a kind of theoretical explanation, but there are some evidences. And hexokinase 2 is important in maintaining the highly malignant state of cancer cells by closing voltage-dependent anion channel and preventing mitochondria-mediated apoptosis. In summary, differences of retention index values, retention index in malignant tumors may be associated with different expression of hexokinase 2, as you mentioned, located in the mitochondria. If FDG moves into the cells via glucose transporter located in the cell membrane, we can calculate the SUV, and it represents the activity of glucose transporter. But to produce ATP in malignant cells, it should be phosphorylated by hexokinase 2. So In addition to the glucosidase buffer, hexokinase 2 is also very important to maintain the malignant tumor. So, if we consider this study, Higashi et al. Studied a group of 21 patients with pancreatic cancer and reported that hexokinase 2 expression of the tumor showed a positive correlation with the retention index, but not with SUV of tumor. There are not so many reports about the histologic evaluation of hexokinase 2, which showed the correlation with the average PET. Some reports suggest that the correlation of hexokinase 2 and retention index, not SUV. By using this parameter, we studied the histologic response of osteosarcoma. As you can see here, retention index measured on the pre-treatment PET, not post-treatment PET. Actually, this study was performed before neoadjuvant chemotherapy and after neoadjuvant chemotherapy. Then the histologic response was assessed by the surgical specimen. Among multiple PET parameters, only retention index was able to predict the histologic response before the initiation of the chemotherapy. It is very important in the clinical practice. Other parameters such as SUV or retention index on the post-treatment PET could predict the histologic response. And if we can predict the histologic response before the initiation of chemotherapy, it is very useful for clinical practice. This is an example. In the upper images, you can, this is early PET and this is delayed PET. You can see significant increase in the SUV FPG uptake on delayed PET. So retention index was more than 20%. Actually, the patient showed poor histologic response based on the post-surgical specimen. On the contrary, in this patient, the FPG uptake showed increase, but the degree was moderate. So retention index was about 5%, and the histologic response was good in this patient. Yes, another way of analysis is textual analysis. There are very many parameters in textual analysis, so I cannot talk about all parameters. But textual analysis may potentially provide the most versatile range of indices that could be used to characterize uptake heterogeneity within the delineated tumor volume. Yeah. If you consider these two images, you can find some differences. In the upper images, there are homogeneous FDG uptake in the tumor. But in the lower images, you can see heterogeneous uptake in the tumor, within the tumor. If we draw the figure, x-axis is the threshold SUV, which means 100% of SUV max and 0%. The y-axis is volume. If the tumor is heterogeneous, tumor shows heterogeneous FDG uptake, the area under the curve is larger than the homogeneous uptake shows the larger area under the curve than the tumor with the heterogeneous uptake, like this. By using this simple method, Kang et al. Reported the differences of survival, which means patients with narrow area under the curve showed poor prognosis, which means patients with heterogeneous tumor uptake showed poor prognosis. But it had some limitation. by using the area under the curve method. The same area under the curve does not always mean the same heterogeneity. As you can see, by using the area under the curve method, you cannot tell the differences between the A, B, C, and D. They same. They show the same area under the curve. So another complicated methods have been developed. Actually, this method was firstly applied to other images such as MRI. But nowadays recently there are many papers using the texture analysis on FDG path. If we go to the region of interest here, this irregular contour, the image, can be converted to co-occurrence matrix. This matrix has information about the intensity, like 0, 1, 2, and the location of each pixel. So we can calculate many texture analysis parameters from this matrix. One of the most commonly used parameter in texture analysis is entropy. As you can see in these images, in the upper images, these pancreatic tumors show with the cutoff as the value ratio of 0.2, we could predict more accurately the lymph node metastasis by using this parameter compared to the SUV of axillary lymph node alone. And in another paper in breast cancer, they showed that the ratio of lymph node to primary tumor was useful for the prediction of prognosis in breast cancer. This is an example. As you can see in the upper images, the SUV of axillary lymph node was 1 point above 1.3, and the SUV of primary tumor was 2.9. As you can see, the primary tumor shows relatively low FDG uptake. So the ratio was 0.44. It was higher than 0.2. So this axillary lymph node was considered as metastasis rather than benign node. Actually, the patient underwent axillary dissection and the node was confirmed as metastatic. Yes, I summarized some PET parameters and I will show you two MRI parameters because there are so many MRI parameters, but so I will summarize two MRI parameters, then we'll show you some examples of combination of these parameters. Perfusion parameters are most commonly used parameter in MRI. K-trans describes the forward leakage rate of the contrast medium. K-trans approximates to tissue blood flow per unit volume in most tumors. As you can see in this image, when we inject the contrast medium, it goes to the blood plasma. Then it will enter the tumor interstitial space. Then the K-trans represents the inflow of this contrast medium into the interstitial space. On the contrary, KEP represents the outflow of the contrast medium. K-trans is very popular in the study of perfusion MRI, but dynamic MRI. But sometimes it is very difficult to calculate the K-trans. It is very vulnerable to the motion or some other artifact. So IAUC is a substitute for K-trans when there is some technical problems. I will show you a case. In our institution, we performed dynamic MRI imaging in this patient. This patient is a patient with osteosarcoma in the right femur. Maybe the same patient as I showed before. The tumor shows in as much here, and we can draw the graph. The x-axis is the time, and the y-axis is the concentration of contrast medium. Then we can calculate the perfusion parameters from this graph. K-trans, KEP, V, and IAUC is a parameters. We at all reported that by using this perfusion parameter, they could predict the survival of breast cancer patients with higher KEP, which means higher perfusion rate, showed poor prognosis. Other parameters also showed some differences in survival. The second parameter in MRI is apparent diffusion coefficient, a well-known MRI parameter. ADC is used to quantify water diffusion and tends to decrease in highly cellular tissue such as malignant tumors. As you can see in the left image, if there is no cell, if there is only water, there is a random Brownian motion. But if there is some cells, okay, it is okay. Brownian motion will continue. And free diffusion is possible, and on diffusion weighted image, low signal intensity is seen, and on ADC map, the signal is high. But when there are many cells, the Brownian motion is restricted. It shows a high signal intensity in diffusion rate imaging and low signal on ADC map. We'll show you an example. These images are MRI before and after chemotherapy in breast cancer. On this MRI, you can see decrease in size of the tumor. And on diffusion, K-trans significantly decreased after chemotherapy. And on ADC map, the signal showed increase after chemotherapy. It means that water diffusion is increased, and in contrast, cellularity has decreased because of the chemotherapy. So I will show you some examples of the combinations of these parameters, PET and MRI. In our institution, we have a PET MRI system, but it is not a simultaneous system. This system was installed in 2009. There is a PET scanner on the right side, and the 3 Tesla MRI on the left side.
Software fusion, not hardware.
Yeah, software fusion by using a single software. And there is an anti-magnetic wall. This wall is made of lead about 10 centimeter thick. After the scan, PET-CT scan, the patient walk to the MRI. So these two images are co-registered by using software. In our experience, it was sufficient to study PET MRI studies. I will show you some examples. This is a study flow in osteosarcoma. Before the initiation of neoadjuvant chemotherapy, the standard protocol, we acquired the PET images of the whole body for the staging of cancer, and MRI of extremity is performed BC MRI and diffusion-rated imaging. The same protocol is applied to the second PET and MRI after the completion of chemotherapy. Then surgery is performed and the specimen is acquired. Then the pathologists evaluate the response. If there are multiple shots, the tumor is more likely to be a good response. This is an example. On the left image, you can see a moderate decrease of SUV after the chemotherapy, but the ADC significantly increased after chemotherapy. And in another case, SUV significantly decreased after chemotherapy, but ADC moderately decreased. By using these two parameters, we could predict the histologic response better than the SUV or ADC alone. The diagnostic accuracy was about 85%. Another our experience was to map the specimen using PET MRI. When we measure the histologic response, the pathologist usually measure the necrosis rate at the plane with the largest diameter, for example, like this. They examine the necrosis at the full section. But when we combine the PET and the MRI, we can define the small region with the highest SUV. By using the MRI, we can delineate the region, and the surgeon can dissect the specimen, and the pathologist can evaluate the region with the highest SUV. Here, we published the preliminary data of this study. Actually, we want to compare the predictive values of response rate evaluated by histology response and on the full section, and the histology response on this small region, because this small region will present the highest metabolic activity within the tumor. In preliminary data, the necrosis rate at this small region and the whole region show the significant correlations. It is natural, but we are studying the predictive values of these new parameters. By using the similar method, we assessed the ABC value at the region with the highest SUV. In breast cancer, we draw many regions of interest here, like this. Then we selected the one region of interest with the highest SUV. It was defined as the ABC pad. This ABC showed the highest area under the curve for the diagnosis of histologic rate, for the prediction of the histologic rate in breast cancer. This mapping method can be useful, but for the data are needed to validate. Another simple approach is to combine parameters for the prediction of survival. This is an example. In our institution, we combined the SUV and the MR slope. MR slope is another parameter for dynamic MRI. By combining these two parameters, we could predict the survival better than the parameters used alone. As you can see in this slide, by combining the SUV and the dynamic parameter, MRI parameter, we could predict the survival very accurately than the parameters used alone. We are also studying the patients with head and neck cancer. These patients showed the decrease in SUV in the primary tumor, and the ADC somewhat increased after chemotherapy, and the size significantly decreased. But heat trans somewhat increased, you can see here, after chemotherapy. When we summarize the 6 patients, we saw the significant decrease in SUV in head and neck cancer, and significant increase in ADC, and some tendency to decrease in heat trans. We are ongoing this study. There were significant correlations between SUV, ADC, and SUV in heat trans. Yes, I want to show another example. I showed the combinations of PET and MRI, but there are many other imaging tools in nuclear medicine. One example is bone scan. Bone scan is very popular. In osteosarcoma, cancer cells produce the osteomatrix. So bone scan shows a high uptake in osteosarcoma. But after chemotherapy, the tumor cells will die. Then the amount of osteoid matrix will decrease. also the activity of one scan will decrease, although in this patient it was not so much. We can measure the activity of tumor by the measuring the count in the tumor and the normal tissue. The normal tissue is usually defined as the thigh and the soft tissue region. So we can calculate the ratio of tumor to non-tumor ratio. And after chemotherapy, in this case, the ratio was not so much decreased. But on FDG PET, the metabolic activity significantly decreased. But we can suggest that the metabolic activity of tumors significantly decreased, but the osteoid matrix produced by osteosarcoma cells did not decrease after chemotherapy.
Same phenomenon we see in IVG and bone scan.
Sorry, I cannot.
The same phenomenon we see in IVG scan and bone scan.
Yeah.
IVG and bone. Or IVG may precede the response before the bone scan.
Sure. Yeah. Right. By using these two parameters, we could predict the survival of the patients with the sarcoma, the metastasis-free survival. By combining these two parameters, when we consider the patients with little decrease in the uptake of bone scan and the little decrease of SUV in FDG PET showed poor prognosis than the others. This is another application of combined imaging modalities. Okay, in summary, among multiple PET parameters, SUV max is the most commonly used in oncology. MTV, TLG, retention index, and texture analysis may provide useful biologic information. And the population status of tumor can be estimated by using this MRI, and the cellularity can be assessed by this map. Combined use of multiple imaging parameters may increase the diagnostic accuracy or prognostic value in oncology. However, the optimal imaging protocol and the criteria should be determined for clinical use because the cutoff value is different according to the study and according to the imaging protocol. So the larger population should be needed to validate these clinical studies. Thank you very much. Is there any question or comments? Yeah.
I just want to ask about the retention index. How long do you delay before you take the SUV for the retention index?